So welcome everyone to the childhood myopia management session, and we have a keynote lecture by Dr. Harbansh Lal, who will be speaking on use of intracameral phenocaine.
Hello. Yeah. So good morning, friends. So my talk is use of intracameral phenocaine. No financial disclosure to make. Is mydriasis a concern for the cataract surgeon? We know that if we want to do safe, simple cataract surgery, we need a really good dilated and stable pupil. And the complication rates are very high if the pupil is unstable or the pupil is small. So if the pupil becomes small intraoperatively, or even the pupil is not dilated and we do not use the AIOC and dilators, then there are more chances of iris trauma, because if you go closer to the iris border, it will get sucked into the phaco tip if your settings are high. And once it gets sucked into the phaco tip, there are so many inflammatory mediators are released. There are more than 36 types of inflammatory mediators which are released, that the pupil starts becoming smaller and smaller, and that area gets partially destroyed forever. Whenever you will see the post-operative, you will see the white spot and atrophy in that segment. And if we keep the phaco settings on the lower side, then removal of the nuclear fragments becomes difficult. So we have got to be nearly at least 1 millimeter away from the pupillary border to do our maneuvers. So if the pupil is small, then it becomes a little tricky. And there are more chances of posterior capsular rupture in cases of a small pupil. And particularly if it happens to be soft cataract, then you go inside, you can't see, and suddenly there is a cataractous material sucked and you can see the PCR over there. The prolonged surgery time also increases the risk of endophthalmitis and macular edema and inflammation and corneal edema. So if it is a prolonged surgery, more fluid going in, more time you are taken, there are more chances of post-op eye not being quiet, vision not being 6/6 as you wish your patient should have next day. So what happens if the mydriasis is good? Then you are able to do good capsular access. Whenever I train my residents, I ask them, because the residents have got a tendency to make the CCC small. They are really scared that the CCC might run away. So with that fear, they tend to make it small. And from the small hole, when you want to take out the material, it becomes tougher, whether it's a nucleus removal, whether it's a epinuclear removal, whether it's a cortex removal, whether it's IOL implantation. That means every step of surgery becomes difficult. But if the rexus size is good means all the rexus size should be between 4.5 to 5.5 millimeter of size. We don't need the rexus more than 5.5 millimeter in size, because we want our IOL optics to be covered by the CCC. But if you got to err on the smaller side, it's better to err on to the bigger size. That means if the rexus is 6.5, particularly if you are operating hard cataract, no harm will be done to the patient and your surgical steps will be easier. So when we want to do a cortical cleaving hydro dissection, if the rexus is small, there are more chances of the posterior capsule opening up, because the fluid is not able to come into the anterior chamber and then we pressure onto the posterior capsule. If we want to do the capsular polishing, it is easier. IOL implantation is easier, particularly the 3-piece lenses. And if there are some 4-piece lenses, other big lenses, so that becomes much more easier. And for accurate positioning of the IOL, also you need a well-dilated pupil. So there are some disadvantages, not a major disadvantage of topical medication. One is the delayed onset of mydriasis. It is not instantaneously. So I got to time the patient. Like suppose I call my patient at 7:30 a.m. in my theater. A patient is coming all the way from the Mathura to get his surgery done. So I got to tell them, when you get down half an hour, 1 hour before reaching my center, go for a loo, taking a cup of tea, please put a drop at that time. Then as soon as you enter the hospital, you put a drop at that time by the time formalities are being done. So if he puts at, say, at 5 a.m. when he's traveling from his hometown and reaching at 7:30, that means there may be iris fatigue. So you have got to time the pupillary dilatation so that the pupil is adequately dilated and there is no fatigue. And there's some ocular toxicity is definitely there because of the medication, and the pupil may be inconsistent, and there are more chances of intraoperative miosis, and systemic absorption, particularly phenylepinephrine, may cause increase of the blood pressure. In cardiac patients, it may be a little tricky. So now we are lucky to have the product available to us, which is called Phenocan Plus, and we thank the Antode for bringing out this product, which is ready-made. I have been using Gilocard Adaline in all my patients. I never operated any patient without Gilocard Adaline, even if the pupil is fully dilated. So I was doing topical phaco. I was the first to start the topical phaco in North India. And there was a lady from US, I don't remember. So she was talking up the intracameral Gilocard. I said, I operated thousands of cases without putting the drops. What is so big deal about it? She said one sentence, use it, your patient will appreciate it. Our patient doesn't know how much pain should be there when you are operating. So, but we know that if you put on a Gilocard, patient will be far more comfortable and happy than if we don't use it. So it's very, very important that we make our patient comfortable. Not only this, I keep Jalocaine 4% a bottle, I autoclave it, and which is on the sister's trolley. So on a critical step, particularly when I'm injecting an implant which is a wound supported, I put a drop beforehand because the whatever drops you are using, it may wean off. Anytime patient is uncomfortable, now you got a sterile 4% Jalocaine on your table, you can keep on pouring it instead of taking from the vial outside and put it over there. So this product has got a tropicamide, phenylepinephrine, and lidocaine all mixed in one and can be stored at a room temperature comfortably. So 95% of the pupil dilation was achieved within a mean of 28.6 seconds. It takes even less than that most of the time. And the mean pupil diameter was around 7 millimeter, and it remains stable. And there was no clinically significant change while the surgery was going on. Less than 1 millimeter of change was there. So I'll show you some of the video. So now this is a fully dilated pupil, absolutely no problem. You can go ahead and do the surgery, but I want the anesthesia and maximum possible dilatation. So even in this case, I'll put a little bit of Phenocan inside the eye. And now you can see the pupil is far better dilated and stable. So even, and you can put the toric multifocal or whatever lens you want without any problem. So this is slightly mid-dilated. So borderline pupil, if it starts becoming a smaller, maybe a problem. So I will like to really put a little bit of Phenocan in this so that if it gets dilated, fine. At least it should not becoming a smaller while I'm operating. So at times the pupil may be closed, you may not see any benefit, but it remains then stable at that size, whatever it is. So this is a little much more smaller pupil. We use it over here. There is no dilatation, no problem, but at least it will remain of the same size. And if need be, if you feel comfortable, cataract is not complicated, you can go ahead and do the surgery on this pupil size, and you can use the viscodilatation if needed little bit to do the making the rhexis, which you can make under the pupillary border also. So you put on a viscoelastic to dilate it, and if you do not feel comfortable, you can always use rings or hooks to do it. And in this case, we have put high viscosity viscoelastic. You can see that I'm putting onto the pupillary border, and pupil is getting stressed. So you can add approximately a millimeter of dilatation, may be done more, and then you can do the rhexis. Go ahead and do the rhexis at the pupillary border, even beyond the pupillary border. There is no problem because with the turn of the capsule, you can see where the capsule is. Even if the pupil is small, your rhexis should not be small because what holds back the nucleus is the rhexis, not the pupil. So pupil is only you have got to avoid the trauma to the iris, but it is the rhexis which causes the problem when you are operating. So at places you can see that my rhexis is either on the border or even beyond the border. So my rhexis size is definitely around 4.5 millimeter or so, at least more than 4 millimeter. So this way you can complete the surgery. And particularly, you got to be careful when you do the hydrodilation. If you inject too much of a fluid, there is a sudden pressure and irritation of the ciliary body and iris, and people may become smaller. At the same time, we want good rotation of the nucleus. So you may have to do multiple site hydrodelineation to complete this surgery. So but if this pupil is even further smaller, so in this case also I will inject the phenocane, particularly to anesthetize the iris. Even if it does not get dilatation, it will sustain, and at least there will be anesthesia, because all my surgeries are in a topical medication. And after putting this phenocane, if it does not dilate, then you know that this pupil is too small to complete the surgery. So either use any of the ring devices to go ahead and do the surgery. So do not continue to do the surgery in such a small pupil. And some patients are allergic. A patient had shown somewhere else, and he said after putting the drops there was allergy. We do not know which drop it was. So in such cases, or the patient has forgotten to put the drops. Some patients just walk in your clinic. Some patients come from out of the town and they want to get their surgery done immediately. So you can just go and put the drops without any prior medication, and these people dilate beautifully on the table itself within a matter of seconds. So you can see that there is instantaneous dilatation when you put these drops, and you can go ahead and do the surgery. So the advantage is the prompt onset of pupillary dilatation. You are actually with this available and into your inventory, you don't have to worry that whether pupil is dilated well or not, whether staff is putting the drop outside or not. No, I ask my staff, don't worry about it, because there are a lot of things to do already to see the BP, see the blood sugar. So now you keep on adding the drops and then keep on checking whether the pupil is dilated, no more required. There is a stable mydriasis, safe and effective alternative with the less risk of systemic exposure, particularly in cardiac and hypertensive patient. Significantly less pain or sensation of pressure, and this is DCGI approved, and there is a AIOS guideline also available, those who want to read it. And particularly if you are doing it under block, there is not a problem, but if you are doing any topical surgery, whether it's a glaucoma or whether it's a cataract or any other intraocular surgery, now we do virtually all intraocular surgeries topical, please do use some anesthetic and mediatic. Thank you for your kind attention.
Thank you, Dr. Harbans for an excellent presentation, and no doubt this has actually revolutionized management. Thank you. It's actually revolutionized the management and has really eased us for all categories, all types of patients, as Dr. Harbans has mentioned. It is really a convenience now intraoperatively. Thank you, Dr. Harbans.
Yeah, if anybody has got any question, I'll be more than happy to answer.
It's been a crystal clear talk, sir.
Okay. Only thing is there was some debate about it, whether we should use it routinely or only in a selected cases where pupil is not dilated. I use it routinely in all the patients, even if the pupil is fully dilated, because it acts to anesthesia, it keeps it stable, and I don't have to change my surgical step. My staff knows, my sister knows that after this instrument has to come into my hand. So they always know as soon as I made a side port incision, my hand goes out, I know that the phenocane is in my hand. The next time the hand goes out, the viscoelastic is in my hand. Next time it goes out, they know that they have got to 2.8 millimeter or 2.2 millimeter keratotome. So if your steps are smooth line, and every step, every time, your staff is very comfortable and you are also very comfortable.
Absolutely. I also use it routinely now. It's a part of my step to prevent intraop meiosis over time. So if the pupil starts coming down, you're still struggling and you feel, no, I can get away with it, and then you have an iris shaft. After
sir,
that, it's very difficult to get it to dilate again.
Sir, I have a question actually.
Yeah.
I mean, for pupils which don't dilate preoperatively with tropicacil and phenylephrine T+, they don't seem to be responding very well with phenocane also. Does it,
so if you have not dilated, there is no problem. But at the same time, there is no reason not to dilate also. So that means you don't have to be off. Earlier we were obsessed about preoperative dilatation. We don't have to be obsessed, but I think adding one drop is good enough, because then I think it's better to have one drop at least put preoperatively. Yeah. What was it?
Thank you.
My
Thank you, sir.
question
Yes, she wants to.
Sir, my question is like, are you using in infants, in pediatric cataract surgery also Phenocane Plus? Because
Yes,
in
yes,
infants we
yes.
have issues with the dilatation of the pupil.
Yeah,
So
yeah,
are
yeah.
you using?
Just a little careful, you have to inform your anesthetist about it, because if the blood pressure goes up, then you have to inform them, they know it's all okay.
Even in the cardiac patient, other patients, because the quantity which you put inside is too small. And if you got any doubt, so immediately you take a viscoelastic and whatever is inside comes out and ask them to wash it. Because from the intracameral absorption to the system will be much less, it will be the conjunctival absorption which will be more, and to the sac will be more. So if you wash it out immediately, so there is hardly anything which required over there. So there is nothing to worry about. The cardiac patients are pediatric
Okay,
cases.
thank you, sir. I think we'll go on, we'll discuss it later. We'll go on to the next part of the symposium so that we are not short of time for the next. I'll request our first speaker, Dr. Jyoti Matalia, to come and start her talk on optical interventions for myopia. We'll now go on to the next part of the symposium, which is on childhood myopia management, an extremely pressing need and an important topic of discussion now world over and increasingly gaining importance in India. So we'll start with the optical interventions that are available for us in the management of myopia, and there are now significant number of them increasing our repertoire of management. So Dr. Jyoti, please. She's from Narayan Netralaya, has a huge body of research in this area and with a large patient follow-up. So Dr. Jyoti, please.
Thanks, Dr. Rohit, and thanks for inviting me to be a part of this childhood symposium on myopia. So as we are aware, we are coming out of a COVID pandemic. We have issues that are going to be coming subsequently, and that we are talking about is myopia. And myopia is now going to be progressing significantly. This is the global prevalence, and what has been studied is that almost 50% of the patients are going to become myopic by 2050. That means 1 out of every 2 patients will be a myope. And of that, 10% are going to have high myopia, and we know what the implications can be. So what we are going to be discussing today are the various options of myopia control, and what I will primarily talk is about the role of optical interventions in myopia. So let's understand what are the theories of myopia progression. One is the feedback, the emetropization, which is common that we are aware as the child grows. Then the dopamine, low dopamine is known to cause axial elongation, and similarly, a lot of issues with scleral biomechanics, which can also be an implication. Accommodation lag, and one other option, that is a peripheral refraction. And I'm going to be primarily talking on this because this is the concept behind the optical intervention. So what do you mean by hyperopic defocus? So when you have using a single vision glasses, you know the central part is focused on the retina, but the periphery gets focused beyond the retina. That is a hyperopic defocus, and that is the reason why these patients can have myopia or axial elongation. That is the important. And for that comes the defocus devices, where peripherally, there are certain areas of defocus in your glass which causes a myopic defocus, and this myopic defocus can prevent your number from going up, and that is the concept behind these devices. And for that, we could have various options, like we have the defocus glasses, that is the peripheral defocus ones, and the contact lenses. But let me first enumerate which are the various optical treatments options there. So we have the options of glasses and contact lenses. Glasses, there are the single vision with undercorrection or progressive addition lenses, but they're of no use now in trying to control the myopia progression. So what we look at is the defocus or the contrast alternating ones. In contact lenses, we have the options of rigid contact lenses or the orthokeratology, or the soft bifocals or the multifocal contact lenses. So I'll try to talk on each of them. So looking at the spectacle options, we have 4. That is a defocus incorporated multiple segments by Hoya, that is a DIMS. We have the highly aspheric lens sets, that is HALT, that is by the Stellist, that is introduced by Essilor. The diffusion optics technology DOT by Essilor, and cylindrical annular refractive elements CARE by Zeiss. So let's look at each of them. So this is basically a glass which has a central clear zone of 9 millimeters, that is for distance refractive correction. Beyond that, there's a 33 millimeters of area where there are 400 multiple defocus segments, each diameter being about 1.03 and having a plus 3.5 myopic defocus, which is fixed. And this is meant to act along with the central, causing a myopia defocus, therefore preventing the axial elongation. Then second, we are looking at the Hall technology, that is the Stellist, where as you can see inside, there is an exactly a myopic defocus, entire bowl volume of defocus produced by the glasses. That is the A in front of the B, where is the focus on the retina. And what it has is 11 segmental rings, as you can see. But here, the amount of myopic defocus is not fixed. It can vary depending upon your central refractive correction. Then comes the diffuse optics technology. This is different. What they say here is that the abnormal contrast between the cones in your retina can be responsible for actual elongation, and this is what it does. So the central part continues to be fixating and has the correct refractive correction, but around that there is a significant low contrast, multiple dots, which probably would eventually prevent this myopia progression, and this is still not come in, and it's in the process. And finally, the CARE, that is the cylindrical annular refractive elements by Zeiss. These you can see are multiple cylinders which are there, which cause the myopia defocus. They are incorporated on the anterior part, and this defocus is what will prevent the actual elongation. Thus, we have 4 options, and you can see these 3 options primarily are considered with the defocus principle, that is the myopic defocus they create, whereas this talks about modifying the contrast. Now then we come on to the, let us understand whatever we are talking about, what is available is the DIMS and the Hall technology, where we have a lot of papers. Zeiss is coming into it. But what it primarily shows that there is a slowing down of myopia progression by 60 to 70%, more so in the Chinese population. Unfortunately, we don't have any proper publication which talks about Indian population. Also now coming to the other aspect, contact lenses. So here we are looking at 2 options. One is the ortho-K. These are the night wear contact lenses, where you can see an ortho-K is like this. The child wears the contact lens, sleeps throughout the night, minimum 8 hours required. In the morning, there's a modification. The advantage being that the next day, he doesn't have to wear any lenses or glasses for the whole day till he wears the night wear contact lenses. So children who are not interested in glassware throughout the day, this becomes a very important option. Then the other options are the soft CLs, that is the MySight or the AIOC2024, where you have these are basically daily wear contact lenses, where they have the same concept of treatment zones creating myopic defocus versus the correction zones. So both are the same concept that you work on. But we have to note that there is a certain limitation when you order any of these. So the spherical equivalent of all should be less than -10, and the maximum cylinder for the DIMS and HALT is about -4. Regarding ortho-K, not more than -2 is what is allowed when you basically decide to order it. So to summarize, what are the various options to include for myopic defocus? We have the DIMS glasses, the Stellase with the Hall technology, the CARE by Zeiss, the ortho-K and the soft OK, which are presently available. But unfortunately, there are no optical treatments, though we have multiple long-term studies in terms of Indian scenario are necessary, and we don't have it, and it's a need that we all collect our data and get information of how they are doing. But incidentally, now that we are talking about peripheral refraction, I would like to give you the data that we have been using. We have an open field autorefractor which have been used, where we make the patient look at distance and do the peripheral refraction. And what incidentally we found that we have about 54% who have myopic defocus. So what we are assuming that is the peripheral refraction having a hyperopic defocus causing myopia progression is then not sure, because we are getting more of these patients with myopia progression having a myopic defocus. We have only 46. So comparatively, we have more patients having myopic defocus. Also, what we noticed that the amount of progression noted in both the groups were same, those who had the MD versus HD. And we found that majority of these patients were having in the nasal field in those with myopia progression, whereas those with the temporal hyperopic defocus had in the temporal quadrant. So what we do is the advantage of doing this, and I just want to tell you, even if we have the machine, this can be done even without a machine. All you need to do is train your optometrist to make the child look in the particular direction to induce a 20 degrees and 30 degrees nasal and temporal quadrant. And if you're able to do that, you can plan the treatment option. So we had totally 228 cases, of which 122 had myopic defocus and the other ones had 106. And then we decided to alter it. Now, as I said, average difference was about 1.3, and you can notice that we had myopia defocus as high as 4.6 in 1. So it can be significantly high, not like marginal. And hyperopic defocus was as high as 7. So what we did is, those we had myopic defocus, we treated them with low-dose atropine. Some of them insisted on glasses, so we give them to them, and we had 11 who refused treatment. But for hyperopic defocus, we definitely give glasses. We know it is definitely going to work in them, so we had about 50% of them giving the glasses, ortho-K in 3 of them, and low dose in 4. But some of them refused, so we kept them on treatment. But what you need to do is, irrespective of whatever treatment modalities you give, lifestyle modification is very, very important. We cannot just give these glasses and expect the child to be constantly indoors, not going outdoors, constant near time. So this is very important. In addition to your treatment, please reinforce lifestyle modifications. So this is our data that we have been collected. This is done from Jan 2023 to December, and hopefully for the next years, I will have better data to tell what we did and how these patients behaved. So thank you very much.
Thank you, Dr. Jyoti. Do you have any comments from the panel? And meanwhile, I would request Dr. Rohit Saxena to be ready with his presentation, in which he will be speaking on unanswered questions on myopia.
Ma'am, I just wanted. Hello. I wanted to know your experience with Ortho-K, if Ortho-K lenses.
So presently we have given about 60 patients with ortho-K. This was before our peripheral, and we are finding that they are doing pretty well. But unfortunately, our data is less than 1 year. So what we hope to do is all this data where we have collected of glasses, even atropine, we are quite aware, we are following up. We'll probably present in the next, another 6 months later we'll have, but we have none of our patients actually on whether it is a glass or it is an ortho-K had to be given any additional treatment. But what we tend to follow is every visit that they come, we ensure that we are calling them every 4 months. We get the action done at each visit. And we ensure that the lifestyle is reinforced each time. Because many a times that's forgotten. We give treatment, we don't try to reinforce. It's like a diabetic patient. You are giving him medications, but if he continues to eat everything, he's not doing exercise, it will work the same way. So this I keep on reinforcing. One thing that I would like to tell about ortho-K is that when you are introducing ortho-K, you've taken the axial lens prior, 1 month post ortho-K, please get the axial lens done again because it can modify. And then what you follow up the patient will be on that measurement of your axial lens for your subsequent visit.
Studies have shown
You are Dr. Jo.
ortho-K with low dose
It's not on, ma'am. It's not.
Oh, yeah, that's. Hello. Yeah, studies have shown that ortho-K, combining ortho-K with low dose atropine has about 55 to 58% better results than only ortho-K.
But I would always start one intervention, wait for it. If I'm able to show that it's progressing, it's better to add the other one. Right.
Yes, sir, you have a question.
Dr. Jyoti, you said that the refractive index of these polycarbonate glasses is 1.59.
I'm sorry, I didn't get.
Refractive index of this polycarbonate glasses is 1.59. You told in your
No, I
presentation.
didn't mention anything about refractive index. I just told.
1.59 you have mentioned, no?
No, I have not. No, I have not mentioned about the refractive. I was just talking about the amount of changes that hyperopic defocus, the amount of diopter defocus. I have not mentioned about refractive index of any class.
1.59 you have mentioned in your just slide.
You can go ahead with your question, sir.
Yeah.
Any question related to that?
My question is, normally the refractive index of 1.59 is there, which are 1.5 millimeter thick polycarbonate glasses. We come across sports personnel, a child is there who is playing sports and all. In that, even 1.5 millimeter polycarbonate glasses may not be good enough. We may have to give 2 millimeter or even 3 millimeter. There the refractive index becomes more. Instead of, normally it is 1.59, which glasses we are using usually. There refractive index goes to 1.71. So, can we use, will it create any problem? If we use 3 millimeter thick polycarbonate glasses, which have got refractive index of 1.71, so
Yeah, I don't think
will be
that-
tolerated?
Yeah, the thickness of glass for protection, I don't think would make any difference. What we are
No,
trying
it
to...
makes 1.5 millimeter is refractive index 1.59. If it is 2 millimeter, it goes to 1.61. And if it is 3 millimeter, it goes to 1.71, 1.69 or 1.71. Refractive index do changes.
But I think
with
that
the
would not
thickness.
really bother in terms of the myopia progression. What we are looking is changing the parameters to prevent
No,
a
what I
progression.
want to say, you are the polycarbonate glasses which we are giving. I want, there are many children which we come across who are playing sports also there. So for them, we advise polycarbonate glasses, but it should be 3 millimeter thick.
Okay, yeah, sure.
So
Okay,
this
yeah.
is going to create any problem if the refractive index changes. The refractive index is the main thing. Glasses, it is 1.5.
Sir, there are two different things we are actually talking about. We are talking about myopia glasses, which have a separate, which are conventional, built on conventional lens material. The polycarbonate glasses for sportswear are different, so that time the myopia, depending upon
Those
the
who are
thickness and
myopic.
protection. So they need not wear, in fact, they should not be wearing these very expensive glasses while in sports. because it is a heartbreak to the parents if 18,000 glass gets broken when the child is playing cricket. So in fact, that's what we advise, that when the children are outdoors playing active sports, they should switch back to their conventional glasses. Studies have shown about 8 hours
rather
of...
in sports, polycarbonate is there because
Sir,
polycarbonate
polycarbonate
is
glasses
8
are
times
for
strong.
sports and protection. They have nothing to do with myopia progression. So here
Okay,
we are
nothing to
focusing
do.
only on myopia
But
progression.
they are very strong and they are advised for sport
Wonderful,
personnel.
absolutely, sir. You are absolutely right. We should ask them to wear polycarbonate for protection.
I think we
Sure,
can
sir.
go for
Thank
the
you.
next. Is Dr. Ming Wang Hee in the audience?
Can we have the presentation of Dr.
Yes.
Rohit Saxena? Yeah.
So, thank you very much. Thank Entort for giving the opportunity to discuss this very, very important thing. Unfortunately, I have to speak before Dr. Sumita, who was to talk on the pharmacological aspects, so I was to cover areas which are still unanswered. So we'll go through unanswered questions, and maybe some of them, maybe Dr. Sumita will come and respond to. So we don't know why myopia occurs. We still don't know. There is no clear study that can give us proof as to why over the past 30 years, across the world, irrespective of race, myopia is progressing. It does not matter which part of the world you are in. It does not matter how long daylight hours there in that country, from north to south, across all continents, myopia has shown a distinct progression across the world. Unfortunately, some areas we have seen a far greater progression, particularly East Asia, where the prevalence is almost 70 to 90% in 5 to 15-year-old children. So imagine a class of 50 children with 5 children not wearing spectacles only. So that's the kind of impact that's happened world over, including India. So we have been seeing a progressive increase in the prevalence of myopia in our children, generation after generation. We know in 30 years the genetics has not changed. So there is very, very clear understanding that myopia is probably the youngest lifestyle disease to affect human beings, and we must treat it as such. As I mentioned, genetic factors have not changed. There was a very interesting Singapore study which evaluated the prevalence of myopia in the Indian immigrants. In the first generation immigrants, it was about 13%, which is corresponding to what we expect the myopia to be in affluent Indian urban children. But the moment the second generation came, the myopia jumped from 24 to 26%. So you can imagine that it was the new environment that the next generation was brought up in, and not really the genetics. There are a lot of still, despite outdoor is something that we have been talking about. Dr. Jyoti also mentioned about it. It is probably the single most important thing that we need to mention, but still, there are questions. How long is effective? Most studies have said about 1.5 to 2 hours of outdoor activity. Now, it does not necessarily require them to be in active sports. Essentially, be there in outdoors in bright light. It does not necessarily mean in bright sunlight. In a country like India, in the afternoon, you can't just send your child out. He'll have to require admissions and IV fluids. So outdoors in adequate illumination, even in a covered area. You can even ask the child to read on the balcony, read on the terrace. So outdoor illumination, how long, we're not sure. What is the luminescence levels? Again, these are controversial, but still we know that any outdoor activity of about 1.5 to 2 hours will help. Amount of neo work. Again, there is no very direct, clear evidence and correlation between the two, but we know that what has changed in the past 30 years in East of Asia, and something that is progressively changing in India in the past 10 years, where we have seen a spurt, and again another spurt that we saw post-COVID, is probably related to the excessive use of near devices, digital devices, where you're keeping them so close to your eyes, particularly your phone. So these things have to be stopped in children. These children were never supposed to read on a phone. They were supposed to go outdoors and play and read for only modest times. Now, the attitude has changed. 2 years ago, before COVID, parents would come and say, my child sees television for 2 hours. Please stop him. Today, the parents come and say, my child is on the phone only for 2 hours. So you can see the sea change in the attitudinal difference. Now, 1 year, 2-year-old children have their own tabs and phones to play with. So it's something that it's a ticking time bomb that we are sitting on. Of course, the other problems of risk of sun exposure, feasibility and implementation in a country like India in summers, as I mentioned, it may be really difficult. And the role of vitamin D, it's confounder. Many studies have said vitamin D has an association with myopia progression, but it is a very, very close confounder with outdoor activities. We don't know. The next thing we don't know is how is atropine working. We know across the the world, except in a few Caucasian studies, atropine is shown to be very, very effective. 0.01 is found to be effective in almost all studies to a greater or lesser extent, but we still don't know how it works. We had found amount of atropine penetration in the cornea, in the vitreous and the aqueous to be of substantial measurable quantity. We do not know whether there is a direct correlation, but at least we know that it is reaching up to the posterior chamber and may possibly be affecting on the choroid and the sclera where it is supposed to act. The other important thing to remember is there are some anterior segment changes that can be seen with the use of atropine because of relaxation of the ciliary body. So some amount of myopia is adjusted for by that. That is why possibly there has been that continuous dichotomy between reduction in refractive error and reduction in axial length that is seen all across. So part of that correction may be due to the anterior segment changes. This is the possible cause of disconnect and possibly may be responsible for some rebound. Again, this does not mean that atropine does not work. It just means that we have to understand the impact in every child, and now axial length progression becomes the key important thing. Dr. Jyoti talked about peripheral refraction is mandatory. I would say that the evidence is still out. I do not think that at the moment it is mandatory. Most studies that have used spectacles have not actually released their peripheral refraction data. The theory is that there is hyperopic defocus in the periphery, and that is causing myopic progression. But we've seen these lenses work in all kinds of refractive errors, peripheral refractive errors. So it's the bad news that we may not be right in our hypothesis that it's peripheral hyperopia that is driving myopia progression, but the same thing is good news that you can use it in any kind of patients and probably get impact, maybe to a lesser extent, but still it is effective. We still are understanding amount of progression on treatment. We know that younger children do poorly. Our response is poorer to atropine and possibly to spectacles also. If they have had a high baseline rate of progression, again, they may respond poorly. If the response to the treatment is poor, you need to decide whether you want to supplement another treatment. You add an optical or you want to replace it completely if you do not find your treatment working. It's just like glaucoma therapy. You start one drug at a time, you see the response. If the response is not so good or not up to your mark or not expected rate, you switch to another drug. If the response is modest, but you still want more effect, you may add on another intervention. So we have interventions available, and we've seen many of them augment each other. When will we stop treatment in these children, especially now that we are starting treatment in younger and younger children? We're seeing children 6 to 8 years old who are progressing. So we start treatment then. How long? We have safety results of up to 5 years, but what then after? So it becomes very difficult to decide. It is a case-by-case understanding. In younger children, we may even have to continue to 5 years, taper and then stop and maybe follow them up. If there is recurrence, maybe switch to another therapy or restart. In older children, by the time they are old enough, when we know that they are leveling off by 15, 16 years, you may think of weaning off atropine or start reducing their use of their optical therapy. No definite rules. At the moment, there is no clear categorization. I use that this patient, these characteristics, I use optical or I use pharmacological. But bottom line, obviously, ocular surface, poor contact lenses is contraindicated. Very high myopia, high cylinders, as Jyoti mentioned, we can't use opticals. We'll still have to go to pharmacological. If he has decreased near vision, accommodative lag, avoid atropine, he may have worsening of it. And obviously, economics is the background of it all. Atropine drops are very cheaply available. The optical lenses, glasses may cost up to 18 years or more. I hoped we had Migyoung Hee here. He's one of the pioneers of red light therapy, but otherwise also in his absence, we'll just discuss red light therapy. Pre-myopia, a lot of discussion has gone on. Our understanding is that if you find a child of pre-myopia as defined specifically with a child with risk factors with borderline hyperopia or young, less than expected hyperopia, I would still say we advise lifestyle changes and try and impact his progression accordingly and then think of intervention if we have. There are a lot of questions that are still unanswered, and I think with this discussion and maybe in future research, we will be able to understand. So in conclusion, research is going on. We hope we get more and more interventions. Management should be individualized, and patients and parents should we should have informed discussions with them and advise them about outdoor therapy, outdoor interventions, as well as the long follow-up that is required. Thank you, everybody, very much for the attention.
Thank you, Dr. Rohit. And next, if there is any questions, we can take it. And by the time, I will request Dr. Sumita Agarkar to please come on stage for her presentation on how effective is atropine treatment.
Atropine treatment, we continue for 3 to 5 years. But the rebound phenomena is also seen once we stop the atropine. So is it there we should continue 3 to 5 years, or can we continue for many years, 8 years, 10 years?
Sir,
Up to 15 years of age, if we continue. Suppose we have started in a child at 6 years of age, and then after 3 years, if we stop, again rebound phenomena will occur. So I think atropine can be continued up to 15 years. Will there be any harm if we continue till
There is
15
no
years of
evidence
age?
that, you can continue it for whether there will be any harm or not.
Sir, absence of evidence does not mean
Does not
evidence
mean-
of absence.
yes.
So we do not know what we are doing. So the receptors where atropine is supposed to act through were not sitting for us to intervene in. So they have a role. We don't know what's going to happen in the long run. That is why at the moment we have long-term studies of 5 years.
Not more
And
than that.
it is important that we consider tapering them. Rebound is not 100% evidence that it will occur in all cases. So a percentage of children would have stabilized by then. So if there is a rebound, you start thinking of recurrence, repeat therapy, or you think of an alternative therapy. But as I mentioned, because we don't have enough evidence of very long-term therapy, and these children are going to live for another 60 plus years, we cannot say categorically that just because there is no side effect today, that throughout his next 60 years of his life, he's never going to suffer from an intervention we have done when the eye is
60 years,
developing.
of course, not required. Up to 15 years or maximum. After 18 years, myopia is not going to progress. Another
That is
question-
true, but like I mentioned, sir, we do not have evidence at the moment that there is safety enough, and in fact, the drug is at the moment still not FDA approved. It is approved in India, but it is not even an FDA approved drug, atropine, low dose atropine. So obviously they are waiting and collecting safety data before they will allow any drug like this to be used in children for a very long period of time. So that is why anything we have to use with caution. Just because, as I mentioned, there are no hard side effects immediately, it is not that there will never be any side effects with a drug like this.
How earliest we can start atropine? Because myopia, where there is a family history, we can do axial length, and we can detect even at the 3-4 years of age when child
It's
is
difficult
there.
to do axial length at 3 years of age. It is
Unless you do any.
We
very,
can do-
very difficult. You can induce the baby and do the axial length under general anesthesia, but would parents consent to give anesthesia?
3-4 years, there is no need of general anesthesia. We could do,
Yeah.
I'm doing.
If you
at
can, you
4 years
can.
of age.
If you can document the evidence that axial length is progressing, you can give atropine.
So 4 years, 5 years, there are studies. 5 years have been a documented study. 4 years, some people have tried. Again, you do not treat myopia with atropine drops.
treat progressive.
You treat progressive myopia. So if you have a child, uncommon, but yes, if you have a child, younger child, with progressive myopia, you can consider. Evidence is not there, but
Talking
again,
of
it is not
progressive
necessary.
myopia only because progressive myopia, there is a genetic history. Earlier also siblings has occurred, and now this child is there. So I'm talking of progressive only.
So
So we
again,
can start at 4 years of age.
you can start at 4 years. Again, if you have evidence of axial progression, sir, remember, there are in that age group corneal changes also, which may mimic refractive error progression, which we must rule out. So if you have documented axial progression, yes. At the moment, we don't have data for outlying outside the 5 to 15, 16 years age, but again, anecdotal evidence exists, people have tried, and it should be relatively equally effective. There is no reason for it not
talk
to
on
be.
diluted atropine only.
Yeah,
Dr.
I think
Sumita ma'am.
we'll talk about therapy there.
Good morning. Sorry, some of the overlap with Dr. Rohit's talk is going to be inevitable, and please bear with me on that. So I've been asked to talk on how effective is atropine, and one line I can say, yes, it's effective, and go and sit there and ask the questions to Dr. Rohit. But we have all gone through some scary statistics about myopia, and in India it is probably somewhere around, if you compute COVID thing, it is around projected to increase to at least 35%. So who needs the intervention? When you talk about intervention, progression of 0.5 diopter or more over a year, axial length elongation, and I think that should go even the first point rather than the second point here, 1 millimeter or more, or probably you should use both the criteria to decide on which child needs therapy or which child needs drops. And children who are at risk of progression, like parental history, if one parent versus two parents, if their lifestyles are gadget oriented, and if their sleep patterns are different. There are now very clear correlation between daylight hours, genetic history, and sleep patterns. So if you think your child fits into it, then probably you should look at interventions. So this is the whole armamentarium of the interventions which we have available here. You have pharmacological agents, you have optical devices, you have specialty contact lenses, you have combinations, and we don't talk about it enough, but lifestyle modification is also an intervention. So these are the pharmacological agents which have been tried in myopia control: atropine, low-dose atropine drops, pirenzepine, and oral 7-methylxanthine. Pirenzepine is not commercially available. Oral 7-methylxanthine is only available in Denmark and some European countries, not available in India. So my talk is going to be basically focused on atropine. So we, as Dr. Rohit mentioned, we don't know initially it was thought that it was effect on accommodation, but probably it acts through dopamine release, and it blocks the M1 and M4 receptors in retinal hemicrine cells. And this leads to the release of dopamine, which inhibits eye growth. This is a hypothesis or a postulated mechanism. It also probably has a small effect directly on sclera by inhibiting glycosoma glycan synthesis via non-muscarinic mechanisms. And as Dr. Saxena had already mentioned, that a decreased lens power in children on atropine is probably a postulated mechanism. So contrary to popular belief, actually atropine was tried earlier, as early as in the 1990, where you had the first study by Yen et al. On 2 randomized control studies, which showed a reduction of 60% or more in progression. But the study suffered from lot of loss of follow-up, and that's why it probably did not find traction among the clinicians at that time. Again, another study somewhere near that time also looked at atropine 0.05, 0.25, and 0.1, and corresponding reduction in myopia was 60, 19, and 42, which is something based on what we see today with 0.01. However, in this study, the control group children received 0.5% atropicamide and was not a placebo. So ATOM came in 2004 onwards, and it really changed the thinking. It was the first randomized prospective trial, which had a fairly large amount of children between 6 to 12, a myopia of 1 diopter to 6 diopter, and it looked at the efficacy of atropine versus placebo in ATOM 1. And they could find that corresponding change in spherical equivalent was 0.3 diopter in children who were on 1% atropine versus 1.2 who received a placebo. ATOM 2, which was a further follow-up on ATOM 1, compared the efficacy of lower concentrations of atropine like 0.5, 0.1, and 0.01, and compared it to the historical controls which were enrolled in ATOM 1. And you can see it is fairly effective again. The corresponding change in equivalent over a period of a year was 0.3, 0.4, and 0.5 compared to 1.2, which was for the placebo. So efficiency of atropine was clearly demonstrated by ATOM 2 to be related to the dose or dose dependent. LAMP study, which also looked at different percentages, also proved almost similar point where the best efficiency was seen with 0.02 rather than 0.01. So what did we learn from ATOM studies? That yes, atropine is effective. It is dose dependent, and not only the effect of atropine, but rebound on cessation of atropine is also dependent on what the percentage you used. So it was highest for 1% and lowest 0.01%. We also found that pupillary dilatation was not a big issue, at least with 0.01%. Effect on accommodation and near activities was also least with 0.01%, taking away the need for either both progressive as well as photochromatic glasses, which were given in ATOM 1 study. So effect of axial length, however, with lower percentage of atropine was not found to be significant. And spherical equivalent typically showed better control than axial length elongation with atropine. What is the data from India say? The first study which came out was ATOM study, again by Rohit Saxena et al. And it was a multicentric, placebo-controlled, prospective randomized study with 100 children, aged 6 to 14, and with a documented progression of 0.05. And they found that mean increase in myopia was 0.16 diopter in children who received atropine versus it was 0.35 in placebo. While axial elongation was more in children who received a placebo, but it was not statistically significant in this prospective study. Again, coming to the second study, which is a larger retrospective study, which monitored the progression of myopia, which came out last year in December 23. This was following the initiating treatment with 0.01% atropine. It had patients from 20 centers and almost 732 subjects were enrolled. Mean age was 9.3. Baseline myopia progression was 0.75 diopter, which at the end of year it had dropped to 0.27. And by the end of 2 years, it was noted as 0.24. So what this study added to the information was that myopia control was effective with atropine 0.01%, and it sustained if you put the drops over at least 2 years. Younger children, this study also found, which has a large pan-India enrollment, they also found that younger children who had higher baseline progression had poorer response to the treatment compared to children who are older and who had lesser progression at the time of enrollment. This study, however, did not look at the axial length. So is it universally effective? Is there anything, evidence which is coming to contrary? Repka et al. From a study in USA, they reported that 0.01% was not effective in slowing progression of myopia and axial elongation when compared to placebo. However, a CHAMP study which had larger number of subjects, which was also done in USA with nearly similar ethnic enrollment, but it was multi-preservative, they showed good myopia control compared to placebo. Can I have a minute more? One slide only I have. LAMP study again compared that and they found that 0.015% was more effective. Is there a role of atropine in pre-myopia, as doctor was asking? There are 2 studies which are available with some data. One is by Dr. Jithani, who have reported on efficacy of low-dose atropine in preventing progression of axial myopia. But both the studies had a documented axial length progression at the time of enrollment. Fang et al. Have done it with 0.025 and Jethani et al. Have used 0.01 for children who have pre-myopes. Now, how do you define pre-myopes? Any children under 5 years of age with less than +1 diopter is considered pre-myope, though this is not a universally accepted definition, but for practical purposes, this is the definition which we are all using. So if we look at the evidence, atropine is effective, economical, can work across powers and ages, easily available, and dose strength can be easily titrated because it is available in multiple strengths. Is everything all hunky-dory? No. There is some sobering data coming from subjects who participated in ATOM studies. A 20-year follow-up on subjects who were enrolled in ATOM 1 and ATOM 2 in early 2000s. They were examined around a decade or 2 decades later. At 18% of the ATOM 1 and 40% of the ATOM 2 participants were re-examined, and there was no difference in spherical equivalent or axial length in eyes treated with placebo or atropine. Sorry, that is not known, that is no. And not only spherical length and axial length were similar in ATOM 2 participants across 3 groups. There was actually an increase in incidence of myopic macular degeneration in ATOM 2 participants that corresponded to higher concentration of atropine. So long-term data is still, this study has a little bit trouble in the sense that only a quarter percentages were examined again, and probably what we don't know is how far, and these all received atropine for only around a couple of years, 2 to 4 years, most of these children received. So what we can infer from this study is that probably you need to put atropine longer, and rebound is bound to catch up faster than you think in children who were on slightly higher percentage of atropine. Thank you for your attention.
Thank you, Dr. Samita. Before we go on to the discussions, take questions and comments from our audience, I would, of course, like to thank Entod for one, sponsoring this session. Two, good news is that hopefully sooner we are going to have 0.25 also available in the market. I think a study that was supported by them has come out with a multicentric data, which should get published. The red light therapy also is possibly going to be tried in India in a multicentric trial. Again, none of these are FDA approved, but at least hopefully they will be available for evaluation and management among patients in India. So that's great news, and thank you very much, Entod. Any comments from the panel before we'll take questions?
I wanted to know, do we actually, measurement of axial elongation, is it must for every visit of patient who is on diluted atropine or any kind of?
We do it annually because you are looking at difference or intervention changes annually. So I would not say that there is any, or at the most 6 monthly if you are feeling that you may have to intervene. If you're looking for how much progression, so if the patient is on long-term follow-up, maybe annually, but yeah, in the initial period, 6 monthly so that you can measure for that change, or you can pick up whether your intervention is working or not working.
I would also suggest that you should do K readings also, so that you have both the things in place. You have the K readings, you have biometry is the best way to find out what, if the change has occurred, what is the reason for the change. That is the only thing you have to find.
It was said that myopic macular degeneration was more in atom 2. So has atropine has got anything to do with macular degeneration?
I don't think that was the speculation. I think that related to the magnitude of myopia which these kids had as adults. So I don't think, so what they did find was that unless you can, because most of these children in atom 1 or 2 received atropine for, atom 1 participants received only for 2 years. Atom 2 received it for 2 to 4 years depending on rebound. So at 4 years, and they were all enrolled between say age 5 to 12, so their atropine was probably stopped somewhere in their early teenage. And as they became adults, myopia caught up, equivalent to what it would have happened even if we had not given the drops. So so that probably is nothing to do with atropine.
The study was not powered or structured to pick up long-term therapy. So it's just an observation. So they've just reported an observation. Let us see. As I mentioned, we still don't know what's happening in the long term. So we'll see. It's just a red flag for everybody to remember that when you are following up these children over long term, go back and see them again and try and see if there's anything. So it's just an observation at the moment. It has no correlatable value. The study was not powered or structured, and only a very small percentage, as Dr. Sumita mentioned, actually have come back to review. So we may not know. So you may get good results coming back or bad results coming back, which may just bias the observation we have made. So,
hi, good morning. I have a question. Like quite a significant percentage of my patients who are using low-dose atropine, they complain of burning and stinging sensation the moment they put the drop in. So what is your opinion, sir? And second part of the question is, should we be adding some sort of lubricating before they put the low-dose atropine? Thank you.
Typically the formulation which is made atropine sulfate, 0.01% or 0.505%, it is slightly on the side of acidic pH. So when the first batch had come, I think they had a pH of around 5.8 or 6.2. So what we went back to the pharma, and when we discussed it with them initially, this is around 2 years back. So they said that they cannot make sure that the pH is isotonic. If the pH is isotonic, probably atropine will not really work. So we have to bear with that. Some of the drops are really stinging, and some of them are not that bad. But it is initially when you put the drops, because the pH is acidic, it creates a lot of stinging sensation.
Yeah, that's why many of them are not willing to instill the drop. That is one of the big issues.
So what you can do is you can tell the parents that once the kid is asleep at 12 o'clock, in the midnight also they can put the drops, because the drops are going to work regardless whether the patient is awake or not. So this is what I do in my practice. So
no need to add any lubricating drop along with that. So
I have used a lubricating eye drop, but the stinging actually doesn't go away. Even
it won't, because see, it is acidic pH, no? So it is bound to sting. The time period may reduce, and once you put a CMC drop, you may change the concentration. I don't know, but I've not.
It's not going to help at all. Okay, thank you, sir.
Good morning. I have a question. I have one of my patients, a very small child around the age of 5 years, and started with -6 diopters. So with that, I prescribed 0.1% of atropine, and after that, the parents shifted to America, and there the doctor prescribed 0.5%, and that also in the daytime. So that child complained, that the parents complained that the child is having a very blurred vision in the daytime. So that's why I told them that usually we prescribe at night, but there the doctors are prescribing in the morning, and they are telling that it does not work that way good if it prescribed at night. So what is your say on that?
So most studies have talked about a night dose. It has conventionally started because earlier we were using higher doses of atropine, and if you put it in the morning, then obviously glare and difficulty in near vision becomes a problem. With low dose atropine, we have not seen this. Conventionally, we still continue to use it at night. Easy to remember, whatever little, very few patients, if at all, have talked of glare or a little near difficulty, but usually none. Maybe when we start going to 0.05 or higher concentrations, we'll have it. 1 or 2 studies have mentioned that maybe in the morning may be better, but again, there's no hard evidence for it. Essentially, we advise preferably at night, but it can be done at any time, but a fixed time during the day. Yes, especially if in the day there is a side effect by the patient, observed by the patient, it is obviously better that we ask them to put them at night.
I want to ask one question. It's like once we have given the child atropine, and for 2 years we don't see any progression. So now what is the regime for tapering which you follow in the normal myopes and the high-risk patients who have high myopia? How to taper the disease, the dose?
So we normally, what we tell if the patient is stabilized in 2 years, we normally tell them to start putting it alternate days for a couple of months, and then we see whether if that is working for a period of 3 or 4 months. So it is more like you are trying it out whether whether there is a rebound. If there is a slight rebound also, you want to go back to a daily regime, and if there is no rebound, you can gradually taper it off. So that is how we do it. Yes, almost the same.
Actually, there is, I feel, high-risk myop. I mean, if you have given it for 2 years and there is no progression, then as sir has suggested, I switch over to alternate days for 3 months and then stop, irrespective of what the refractive error is. So.
Good morning, respected dignitaries. So I have a question. We are all talking about the progression of myopia, in which we are talking specifically about the axial length or the power. So is there any value of about the keratometric readings which will define the progression of myopia? And how is atropine affecting, is it affecting the corneal curvature as well, or just the axial length?
There has been a study, when you see in the biometry, when you do, the axial length by corneal curvature, anything you take, if it is going to be more than 3, definitely the patient will progress. So that is one of the criteria you can actually calculate. You can go back and see your biometry. I have done a report on that. So if it is more than 3, you can inform the patient, yeah, definitely you are going to progress, and you can also be on guard and start the patient on active myopia, anti-myopia treatment.
So atropine doesn't have any bearing on corneal curvature and lenticular, and I mean, this is published by Lamp and their group. So they have published in Ophthalmology 2019, I think, but they have published that it has got no bearing on other biometric values except axial length. And why we should do K reading is obviously because you have to document that the change in the glass power is not secondary to corneal curvature. It is actually because of axial length. So sometimes, you have to document that, whether there is a corneal curvature, constant changes in the corneal curvature.
Are we measuring peripheral refractions routinely to go for optical correction, optical devices? Is anyone doing that also?
What?
Peripheral refraction.
Are you measuring it and then deciding the decision to take for optical?
I don't think
Is anyone doing
that
that?
peripheral refraction, I think we heard Dr. Jyoti, she already mentioned that almost more than 50% actually had a myopic peripheral defocus. There's a good study by from LVP, which says that there's a nasal and temporal disparity, where they found that nasal part actually had a myopic defocus. So, so our decision actually is not based on that. Our decision, I would be starting atropine at the first go because it is cheap and easily available. And maybe if it is not working, then maybe more guidelines once they come, we can go.
So actually you have to do the accommodative lag. So there are, before you give treatment, you should see accommodative lag near esophagia, and then you plan. You're going to give a progressive glasses, or you're going to give your dim spectacles.
In nasal versus temporal hyperopic defocus, I think it's the nasal defocus which really makes more of a difference than temporal hyperopic defocus.
We don't know if it at all makes a difference, so to argue of nasal versus...
All the data on the...
No, they have shown that there's a nasal myopic defocus. So then the whole house of cards
on the myopia
falls.
progression, in the animal models, it is the temporal hyperopic defocus which is more
making
important,
a difference.
more important than probably temporal.
But again, in this dim spectacles, actually the central 9 millimeter is the correcting zone, and the other one 33 millimeter. But our pupil will not be 9 millimeter, normal size of the, what we are going to see.
Last comment
so
or question
I had
from
asked
the gentleman
company
before
person
we
also,
close
but we
this
could
session.
not clarify on that.
Now, I have a question. As a clinician, mostly we get a question from the parent when we prescribe, say, -4, -5 lens for a 4-year-old child, that I am not having myopia, my wife is not having myopia, why my 4-year child is having this aspects. I reply them with Darwin theory of evolution. And most of them, they agree. Few of them, they become, slightly aggressive. Come what may, my child is not going to use glasses. I also become slightly aggressive with them, that I am not a policeman, that I shall come to your house with a danda. So it is up to you. I have just... So will you give some better answer, make me answer in a better way?
Myopia previously was thought to be a genetic disorder, so it used to run in family. But now it's more of a lifestyle disease. With the recent advances, we have come to know that it's more of a lifestyle disease rather than a genetic.
No, but when I say it is as per Darwin theory of evolution, when we were Adi Manav, we were born with +4 number. We are supposed to be hunters, hunted animal and hunted animal. Both have to have their far sight better. Now, for survival for the fittest is the theory. For those who excel in studies, settle better in their life. At the age of 1 year, 2 year, we take the child to the schools. So that is probably, and plus add on that is the gadgets, the mobile phone number these days.
Thank you.
Thank you. Thank you.
Thank you. Thank you all for this session.
Thank you very much for comments, and Todd again for supporting this. I can ask the speakers to quickly come up. We'll take a photograph while the next session starts. Thank you.